So I'm Izak. I'm one of the emergency medicine registrars who just rotated through Rahima, so I haven't met you. Uh, this is my formal introduction. So we're going to chat about urological emergencies. We're going to cover Fournier's gangrene, kidney stones, priapisms, those type of things. The majority of this talk does focus on renal stones because it's such a common presentation. But let's get cracking. I'll try to keep it under an hour. Um, right. Okay, so first off, we'll start with Fournier's gangrene. Please don't make the same mistake as Peter Griffin made when Googling Fournier's gangrene. So Fournier's gangrene is actually a necrotizing soft tissue infection because it spreads in the fascial planes. It affects the perineal region, and that's why it's termed Fournier's. Obviously, there's very limited data for the South African setting, but approximately three um, per 100,000 men in the age group of 50 to 79 are affected. This is US stats. And then you can see the fatality rate ranges anywhere from 7.5 to 50%. I would assume our setting is different given our comorbid disease and presentation and those type of things. So just a bit of anatomy. Um, so like I said, Fournier spreads through the fascial planes. So your Colles fascia is attached to the pubic ramus and the sphincter erector, and that connects to the deep transverse perineal muscles. And then also Colles fascia is continuous with Scarpa's fascia, which connects the abdomen and the thorax. And that's why you have this perineal wound that can rapidly spread through multiple fascial planes, and it can actually cause um, a soft tissue infection all the way up to the neck, essentially. It does spare the deep muscle layers because of the fascial planes. In terms of risk factors, the most common risk factors is diabetes, then immunocompromise, if you're immunocompromised, which diabetes is one of it, and then alcohol use disorder. Strangely enough, there's a 25 to 50% incidence of alcohol dependence in patients who have Fournier's gangrene. And then there's other weird and wonderful things, hematological disorders, recent surgery, and then no risk factors actually makes up 10% of patients who present with Fournier's. So it's just to keep that in mind. In terms of the etiology, it's usually related to a gastrointestinal issue, and then followed by cutaneous and urological disease. And that can be anything from perianal abscess, anal fissures, anorectal cancers, UTIs, hydrocele aspiration, vasectomies, circumcisions, especially in our setting where it's done not always in a sterile manner, pressure ulcers, those type of things. There's a classification for Fournier's gangrene based on the micro studies, but we know most of the Fournier's gangrenes that we see is polymicrobial, so that makes up 80% of the cases. But there is a table, and it is important to know because it determines usually your site of infection, but also what you're going to cover with your antibiotics. Okay. The next slide is just to show like on cellular level. So if you start at the left, it's Klebs, which is a gram-negative rod. Then you get Staph aureus, which is a gram-positive bug, and then E. coli, which is also a gram-negative rod. Then anaerobic on the left, Bacteroides fragilis, and then your Clostridium species on the right. Okay, so how do we diagnose Fournier's? This is a clinical diagnosis. There's no need for imaging. It's a clinical diagnosis. And what do we look for? Swelling, pain, and erythema. Those are the three main complaints and the most common things that people will complain about in the setting of Fournier's gangrene. They say overlying skin necrosis and crepitus only is about 20% of your patients presentation. So if you're going to wait for crepitus in the skin, you're going to miss 80% of your patients. And by that time, your patient is really, really sick. And your mortality is going to range in the range of 50. And then, funny enough, the literature says that Fournier's gangrene is actually misdiagnosed as cellulitis or an abscess in 75% of cases. So really, if your patient presents with swelling, pain, and erythema, and they have pain out of proportion, you should really be thinking, this is Fournier's gangrene, and you should be saying, why is it not? But it's Fournier's gangrene until proven otherwise. So, first question, it's open for the audience. What is the characteristic discharge associated with anaerobes in Fournier's gangrene? What do they classically describe this as? Should I nominate someone or okay, tough crowd. They describe this as a characteristic purulent dishwater discharge with associated feculent odor. So that's a classic description that you will find in a patient with Fournier's gangrene when it's character or when it's caused by anaerobes. Okay, in terms of laboratory investigations, there's no specific test to exclude it. There's lab tests that can help you decide, but it should not be used to exclude the diagnosis. Again, there is a scoring system. I mean, I would probably, this is going to be part of your routine workup, but I won't hang my hat on this. And actually, when they did use the scoring system, a score of 6 and above was found to have a positive predictive value of 92% and a 96% of a negative predictive value. But the issues with this specific study was it was actually done by Fournier in the Emergency Med journal. It was retrospective with poor sensitivity among ED patients. It's not externally validated. If you use this, you will still miss 20% of your patients. So clinical, clinical, clinical. In terms of imaging, like I said, if you find gas in the soft tissue, it's obviously then it's there, but it's only present in 20% of patients. In terms of ultrasound, because we love focus in the unit, you can use, and I mean, this is generalizable to all like soft tissue disease and things. We use the staff mnemonic. So the ST stands for subcutaneous thickening. You can see there where my cursor is. So that's near field. So subcutaneous thickening. When you get air or emphysema in the subcutaneous tissue, obviously with the obvious, what they call a dirty shadow, and then a fascial fluid layer of 2 millimeters or more. Okay, so you can use that to help guide you when you do an ultrasound. If you're going to look for collections, you think it might be an abscess or something. This is just to show how sensitive and specific the modality is. Obviously, MRI, great, but I mean, by the time you get an MRI for your patient, the patient's going to be dead. Okay, so again, go back to the basics and look at your clinical presentation. In terms of treatment, resuscitate. These patients need to be discussed with surgery ASAP. They need to come down. We're not waiting for blood results. They must come see this patient. And then in terms of antibiotics, the recommended regime is piptaz and then also clindamycin. If you think there is streptogenes, which produces gas, so that's to inhibit the toxin reduction. And that's actually the SIMDRA guidelines. So you can just look that up on EM guidance. Cool. Any questions on Fournier's gangrene or necrotizing soft tissue infections? If you have a question, you can ask now or you can put it in the chat. Okay, cool. Let's move on. This is, like I said, this is the bulk of the talk is nephrolithiasis or the kidney stone. They say that's the closest thing a man will experience compared to birth. So, and that's how you see them. They come in, it's extremely painful. Okay, so just a bit of background on kidney stones. There's four types of stones, which you commonly get. Calcium oxalate's the most common. Then you get steroid, uric acid, and cysteine stones. So calcium stones can be due to many things. I mean, obviously, you need to look at the clinical picture and let it guide you. So obviously, if you have recurrent calcium stones, you need to go and assess your parathyroids. You need to look at your renal system. Is there any weird and wonderful metabolic diseases in terms of uric acid stones? There is an association between cancer and uric acid stones as well as gout, and it's usually secondary to a high urine intake. Steroid stones are actually produced by infection. So if you get a report back saying that your patient has a steroid stone, think of things like Pseudomonas, Proteus, and Klebsiella. So obviously your patients who have indwelling catheters, but's been hospitalized for a long time. And then cysteine stones, which makes up 1% of your population that will present with stones. So very rare. Epidemiology, the lifetime risk to develop a stone is about 10%, more common in males than in females. The average age is actually 20 years, which I thought was quite young. And unlikely after 60 years of age to develop stones. So, yeah, I mean, we see abdominal pain often. It should be on your radar for almost every abdominal pain that presents to the ED. In terms of the pathophysiology, this is, yeah, just a bit of background. So most stones start as a renal plaque at the collecting tubule in the renal pelvis, and it essentially is in the suburothelium, and then it breaks into the renal pelvis. And once there's a connection or well contact with urine, the calcium oxalate now lay or develop these layers on this calcium phosphide nidus, and that's how your stone eventually develops, and that causes epithelial injury, bleeding, obstruction, and pain. Risk factors, if there's a family history, it increases your risk by 2.5 fold. If you had previous stones, I mean, in the next 10 years, there's a 50% chance that you're going to have another stone. And obviously, your classic metabolic syndrome, diabetes, hypertension, obesity, also increases your risk. Recurrent UTIs, inadequate fluid intake for all the doctors on the floor, recurrent UTIs in your female population, and then also increase animal protein intake is all the risk factors for stones. So, next question. What is the most or what finding do the radiologist always ask for if you book a CTKUB on clinical presentation? And how common is it to have that? Highlight, do you know?
I think renal ankle tenderness or, I think backache.
Yeah, so that's one of the things. So only in 50% of patients that will have renal angle tenderness. Um, Also, only 50% of patients will have nausea and vomiting. And the radiologist always wants to know, well, not here, but where I worked before, is there hematuria? You only 15% of cases don't have hematuria. Whether it's microscopic or macroscopic, 15% of the cases won't have hematuria. So to hang your hat on the hematuria to say I'm going to scan yes or no is irrelevant. You know, if you think it's a stone and you've done the examination and you've done your POCUS and you think it's a stone, the radiologist needs to scan this patient. Cool. Next question. Is this a stone or something else? And what do we not want to miss and label as renal colic? I don't know if there's any interns on the talk, but that is a good question for the interns to maybe answer. So Rakun one, I see you, one of the interns, so maybe you can have a go, and Dr. Ramsden will help you out.
Yeah, I'm not too sure, but I don't know if it would be something related to the GIT, maybe appendiceal pathology. I don't know.
Okay, that's one of the things. What else? I have a list here of about sure 14 diagnoses that you should not miss and label it as renal colic from the get-go. So you had one. Oh,
Yeah,
in the
I
group
think-
at Gia.
What about an ectopic in a female patient?
Yes, 100%.
Mhm.
What else? What else in the females do we get caught because we don't think of it? So ovarian torsion.
You mean
Okay.
like PID on females?
Yeah, so PID as well, but ovarian torsion, very subtle and very
Oh, yeah.
sneaky. And if you don't think of it, you'll miss it. What else? What's the big things? We said this is a disease that presents mainly in people 20 to 60 years. They're usually metabolic syndrome. They have a bunch of risk factors. What are the big things we don't want to miss? And we always look for it with ultrasound.
What
about a triple A?
Triple A, yeah.
Yes, yes, please. I've heard a story recently where somebody diagnosed a kidney stone and it ended up being a leaking triple A and the patient arrested in CT scan. So don't miss that. Then other things, bowel ischemia, pyelonephritis, diverticulitis, pneumonia with sepsis, like a lower zone pneumonia, testicular torsion. Okay, so there's a bunch of things, and that's what makes ED so great. You have all these things that you have to exclude, and you can do a good amount with ultrasound. Okay, cool. So, has anyone heard about the stone score? Okay, so the stone score is actually very nice. It's validated. It was done by Moore and validated by Wang et al. So it's a validated clinical scoring system that predicts the likelihood of a urethral stone in a non-toxic patients. So we should be using it. Okay, we've excluded most of the things. We think it's a renal stone and they have a normal renal function. Obviously, if your patient is big, sick, there's trauma, there's recent urological surgery or malignancy, you can't use it. It's really nice to use it to help motivate your scans and also to guide you. So it's a scoring system, it's validated, and it's just to stratify your patient. It's on MD Calc, so you don't need to remember it. So it looks at your sex, the duration of pain to presentation, origin, are you Caucasian or not? Are you experiencing nausea and vomiting, and then hematuria or not? So 0 to 5, 10% of patients had stones, 6 to 10, 50% of patients had stones. And if you have a score of more than 10, 90% of patients had stones. Okay, obviously, you need to take into consideration radiation exposure and those type of things. But with this, you're probably not going to scan your patient unnecessary. Cool. That brings us to the next big thing. Should we image patients? When and why? So the data is actually, there's so many studies on it, but Smith and Benjamin, this was a big study in the New England Journal of Medicine where they looked at ultrasound versus CT for suspected kidney stones. It was a randomized control study. They had 2,700 patients, and the intervention was ultrasound, and they compared it to CT. And what they found was ultrasound reduced the cumulative exposure to radiation without a significant difference in bad outcomes compared to CT. So if you've done a good history, you've done a good physical, and you are well versed in ultrasound, it's comparable to CT. Just to mention, the primary outcomes of the study was to look at the high-risk diagnosis, so no difference in the radiation exposure. And secondary outcomes was, are there any serious adverse events? And they stated there was no difference whether you do ultrasound or CT, and then they obviously looked at the length of stay and return to ED visits. I will share this. Most of the things are on my show notes, so you can read through it. So, what are we looking for with focus? So before we put the probe on, we want to just know the anatomy. Okay, so obviously this is a comparison, schematic, and then the ultrasound picture. So you want to look at the capsule, the cortex, the medullary pyramid, and then the renal pelvis, and then down there your ureter. So this is actually where you're going to start looking for hydronephrosis. For us in the ED, is it mild to moderate severe? I mean, you can grade it. There's different grading classifications. The radiologist will tell you it's a grade 3 or grade 4, whatever. We want to know, is there hydronephrosis? Yes or no? Because it implies if there's hydronephrosis, it's an obstructive stone. Cool. So what are you looking for? So you're going to look for a hyperechoic bright structure. You can see here on the ultrasound, there's a stone with shadowing posterior to it. So obviously sound waves can't penetrate that stone, and that's going to cause an acoustic shadow. If you put on Doppler, you get what we call the twinkling artifact, because it's all the ultrasound waves that just bounces off that stone at different times. Cool. Another thing that's very useful is what we call the ureteric jet. It's a normal finding. So in a normal person, you'll get these jets where there's intravesical urine ejaculation into the bladder. A strong jet rules out a significant obstruction, but the absence does not rule in obstruction. So you should have a jet at least twice per minute, and it should last for 6 seconds. But I know it says it doesn't rule in obstruction if it's not there, but if your clinical history, your clinical exam, your ultrasound findings, and things are suggestive and you don't see the jet, most likely it's a stone. Okay. So this is how we feel when the radiology is like, oh, but yeah, you guys did an ultrasound. You're going to diagnose stones often, and if you're well versed in this, you can use your ultrasound to determine who should be scanned and who not. Okay, so in summary, obviously we want to avoid CT in low-risk patients. Obviously in young patients, because of radiation exposure, if they're well, they're appearing afebrile, they respond to analgesia. I mean, you don't really need to scan them. So the middle-aged clinical gestalt for stone score and POCUS, and then you can decide if you want to do a CT. Always, always, always CT in the elderly. Just because you can miss things, they can present atypically. and you can pick up weird and wonderful things, and then it might not even be a stone. And obviously, in pregnant patients and pediatrics, ultrasound. We're not going to talk about stones pediatrics because that's metabolic endocrine disease that I think is best left for the pediatricians. Pain management and renal colic. There are so many studies and it's so interesting. And before Tammy asked me to give us talk, I actually posted this talk on the Helen Joseph academic group because we saw, I think on one of my shits, 4 stones. And it was interesting, everyone gave morphine. And the evidence is actually not that great for morphine. So if you go into PubMed or whatever resource you want to use, there's many studies looking at NSAIDs versus paracetamol, NSAIDs versus morphine. And this study specifically was NSAIDs versus paracetamol versus morphine, and that was in 2016 by Pathan. Good study. It was a randomized control and it was double-blinded. And they wanted to see what's the reduction of pain. Was it more than 50% at 30 minutes? NSAIDs, yes, it's 7% more than morphine, but it scored the best. It also obviously has the additional benefit of opiate sparing. Okay, so multiple studies have looked at morphine and renal colic. So in the literature, they actually recommend 2 to 3 milligrams of morphine every 5 minutes until the analgesia is achieved. I don't know anyone that would do that. I mean, can you imagine giving a patient 20 or 30 milligrams of morphine? Next thing, you're going to intubate this patient. Okay, so not a good thing. Another study that I really liked, and it's the go-to drug for almost everything in emergency medicine, is magnesium sulfate. So they wanted to see how does IV MagSalf compare to morphine in renal colic. Again, a randomized control trial. And this was done fairly recently. So it was double-blind randomized control trial in Iran, where they looked at giving patients 50 milligrams per kg of MagSalf to a max of 2 grams, and then morphine 0.1 milligram per kg to a max of 5 milligrams. And then they looked at the score that they give if they haven't, on the pain score that they've used. If there's no reduction in your pain score by 3, they would give you additional 30 milligrams of ketorolac, which is an NSAID. So they included patients 18 to 55 years and who had a diagnosed stone. Obviously, there was a long list of exclusion criteria. So if you had a renal failure, if you had addiction to opiates, if you were systemically unwell, if you were pregnant. So the primary outcome was pain score on a numerical rating scale at 0 minutes, 10 minutes, and 20 minutes. And then secondary outcomes was to look at side effects, mainly due to the medications they get. And this is what they found. There was a 20% of patients in the MagSalf group versus the 25% of the morphine group failed to respond to treatment in 20 minutes, and they needed NSAIDs. There was no significant difference between side effects, which is great. But they found, and this was a really eye-opener for me, that you can use MagSalf instead of morphine. It gives you less side effects. It's relatively safe. It's readily accessible, and you spare patients or them being exposed to opiates, which is great. Okay. Downside is it was a small single center RCT. Morphine is quicker, But again, I mean, it might be nice for us to see, let's give some max health, let's give some NSAIDs and see if we can stay away from opiates. Okay, because in reality, these patients will present in their lifetime many times with renal stones. We saw that. After 10 years, there's a 50% risk of having another stone. So if you're going to go through with opiates constantly, I mean, you're going to aid the opiate addiction. Another study that was quite made some headlines was the lidocaine study. And that was a randomized controlled trial where they looked at lignocaine versus NSAIDs. And that was actually published in the Annals of Emergency Medicine. And all of them had pain reduction at 30 minutes, but obviously the lignocaine group had higher adverse events. So it's not recommended for use. Okay, so don't give your patients IV lignocaine for pain relief for renal colic. Cool. Then, as we all know, in emergency medicine, we like to push boundaries. We like to treat patients based on good case studies, and we sometimes do experiment. And that's where the erector spinae block comes in. It was also a fairly recent study, was a pilot, only on 40 patients, and they looked at is NSAIDs versus a erector spinae block, is it better or not? They found in the study that you actually had to give rescue opiates more often. In the NSAID group, patient satisfaction was better in the erector spinae block group, just because you can, with your Marcaine and steroids, you can actually have good pain relief for up to 24 hours. Obviously, it was a pilot study where it was 40 patients. It wasn't, they need a large double-blinded RCT to confirm this. But it might be an option. You know, obviously, unfortunately, it's difficult in our setting because we don't have equipment. We have one ultrasound. We don't have block needles. We don't have Marcaine. But what we always tell us as registrars, we're being trained for the international environment, so you need to know all these modalities because sometimes you will work in a setting where you have access to this. And I was lucky to work in a setting like that before I became their age. And if they could block something, they would. I mean, we had 5 ultrasounds of a unit. Okay, so you need to know these things because at the end of the day, we also need to make sure that our patients are satisfied with our treatment. I'm not going to go through the detail of how to do this. There's many videos and I can share some links to that. Cool. In terms of fluids in renal colic, another thing, we all like to push fluids for these patients. There's no evidence for fluids in renal colic. It doesn't help. The only role is if your patient is really volume depleted because they've been vomiting so much. Then there might be a role for volume replacement. And then, no urologists like this topic, but again, there's so many studies on this. You've now diagnosed a stone. What are you going to do for this patient if they're not being admitted? So there was studies looking at tamsulosin versus nifedipine versus a placebo. So the general rule is if your patient's not sick, they don't have a deranged UNE, they're not febrile, and they haven't had any instrumentation or abnormal kidneys, and they have a non-obstructing stone less than 10 millimeters, you can probably send them home. Okay, so these studies looked at, is there a difference if you give them tamsulosin or nifedipine versus the placebo? There's no benefit. Okay, but when in Rome, you do as the Romans. So I know for us at Helen and things, the urologist still prefers to give tamsulosin. Okay, obviously it has a side effect profile which is pronounced in your older patients, your orthostatic hypertension and things, but for your small stones, there's really no benefit and a very modest benefit for a stone bigger than 5 millimeters. And you can see again another study done. Given tamsulosin or placebo doesn't really make a difference. But yeah, obviously always go according to what your local protocol says. And then obviously if you're going to give a patient something like an alpha blocker, you need to make sure that it wouldn't cause more harm than good. So when do we admit these patients? So obviously sick patients, renal failure, hypercalcemic crisis, sepsis, and intractable pain blocked. Very self-explanatory. I don't think I have to go into more details. Cool. It's a lot of things. It's one of the most studied topics in medicine because everyone thinks there's a new magic bullet. Is there any questions on this, or can I go to the last part of the presentation? Okay, cool. Last part of this presentation is talking about the ischemic fifth limb. So yes, Priapism. You'll only see it once and manage it in the ED and you'll never forget it. So Priapism is essentially an erection that persists for more than 4 hours in the absence of sexual stimulation or desire. It's a clinical diagnosis. You get a erect corpus cavernosa with a flaccid glans. There's 2 types. So the ones that we're interested in is the low flow, the ischemic one, because you essentially get like a compartment syndrome. It is a urological emergency. Okay, don't let the urologist tell you it's not. This is really something that you need to manage and manage well. The next slide is just a comparison between the low flow and the high flow state. So low flow is ischemic due to the venous obstruction. It causes severe pain. And it's often medication induced or related to sickle cell disease. So the medication, whether it's Viagra, those type of things, or where they get the injection to get an erection. Okay. And then obviously you're going to have acidotic renal blood gas when you start aspirating. Cool. I think I've given most of the answers. But what's the 3 risk factors for the development of priapism?
Viagra use?
Yeah, well, a disease?
Sickle cell disease.
Cool. What other condition can you also get can cause a priapism? So you can actually get it in trauma.
Yeah, I was going to say spinal cord injuries.
Yeah, so your spinal injuries. Okay, so this is a nice little breakdown of how you can classify causes. So medication use. Funny enough, calcium channel blockers for antihypertensive patients, and then your psychiatric patients who's getting trazodone, those type of things, and then others, cocaine, spinal cord compression, cerebral injuries, and then idiopathic. Okay, so how do we manage this? It's fairly easy. Obviously, you need to control the pain. So the best thing is to do a dorsal nerve block, and then you'll go through the rest of the steps. So, where are you going to insert your needle for aspiration of a priapism? You can maybe hold on to that question because it's important. So, like I said, step 1, you're going to control the pain of the dorsal nerve block. Obviously, you're going to use lignocaine without adrenaline, and you're going to inject in the 10 and 2 o'clock position. And you will usually feel a pop as you go through his buttocks fascia. And that confirms correct placement. This is really a game changer. No amount of morphine, fentanyl, whatever you want to give this patient is going to take the pain away. Okay, so do a nerve block to make your life much easier. Cool, you've done the nerve block. Now you want to do oral aspiration. Okay, so butterfly works really nice. And you're going to insert it at the 10 or 2 o'clock position. Please don't, you can see avoid the 12 and 6 o'clock. Obviously, there's important structures that are around there. So you're going to aspirate 10 to 20 mils of blood. You're going to send that blood off for blood gas. If you want to determine if it's a low flow or high flow state, obviously if it's super acidotic, you know this is a low flow ischemic state. While you do this, you can actually ask the patient to squeeze the penis proximally. And the idea is to get that blood to be pushed out into your butterfly or your large gauge needle. Okay, so that goes into the porpora. If that doesn't work, we go to oral irrigation. So usually after 2 attempts of aspiration, they say 20 to 25 moles of blood move to irrigation. I've done this before. I've probably aspirated 2 kidney dishes. I've irrigated. I've gone with the presses, everything, and the patient still ended up going to theatre. Okay, but this is the guidelines. So they say inject 25 moles of cooled sterile saline. They say 10 degrees into the cavernosa. And then after 20 minutes, you're going to aspirate that if it still persists. It's nice if you have a butterfly in there, it just stays there. And you can do that. Obviously, if this doesn't work, you're going to go to phenol. So important, if you're going to start giving phenol, please put your patient on a monitor. Okay. So you're going to dilute it to 100 mics per mol. You're going to inject 1 to 2 mol every 5 minutes to a maximum of 1 milligram. And you're going to ask the patient to squeeze his penis distally. Okay, this is to help get the blood flow back into the body. If I can use that simple explanation. Obviously, if that doesn't work, I mean, you would have probably been on the phone with urology already. But other things that you can do while you wait, there's case reports stating doing squats, walking up and down the stairs works. Debutylene has showed some promise. Obviously, that is not available in our setting. The definitive thing will then be a urological consult for urgent theatre. Cool. And that is urological emergencies in the ED.
Izak, thank you so much for doing your talk for us. I'm very appreciative. I'm going to suggest that people ask questions or make comments. And if you're too shy, please put them in the chat. I can't see any questions at the moment.
Sorry, it was quite heavy on the literature, but I mean, I think it's quite important.
That's awesome. Claire's got a question.
Hi, so it's not so much a question as a comment, just to say thank you so much for exposing us to the Stones score, because especially when you're ordering, I mean, depending on whether you're in public or private, sometimes it's not as easy to get the imaging done for your patient, but at least have some sort of criteria that you're using to be suggestive or to be supportive of your request for the imaging. That's just really helpful. I was not aware that there was a scoring system. So thank you for making me aware of that.
It's a pleasure. What's nice about this, it's a validated thing. So there's ample evidence to show that this correlates well. And sometimes radiology is difficult. And if you can back it up with some solid evidence, it does make your life easier.
Any other comments or questions? I think then you are off the hook. Thank you,
Sorry,
Izak.
I just want to ask a quick question. The conclusion of the best analgesia in a kidney stone. I know you discussed the studies, but what do you find personally works the best?
So, first prize is NSAIDs if your patient can take it. Okay, so that's the first prize. Whether it's IV, NSAIDs, suppositories. There is some patients that are gonna need rescue morphine, or I haven't personally tried the Maxolf. I want to still do that, but I always opt for good NSAIDs first. Obviously, it's a bit difficult in our setting because you have ibuprofen or you have Voltaren. Where I worked before, we had a bunch of things, and we used to give patients actually suppositories when they come in. Works very quickly and gives good pain release for up to 12 hours. So yeah, and the studies support that NSAIDs is still your first line of treatment if your patient has no pulmonary hypertension.
I'm going to be very old-fashioned and put it out there. I have a hubby who has kidney stones. And while it takes time to put up a line and give IV NSAIDs and IV analgesia, there's a dirty old drug that works really well for kidney stones. And it's probably the one time that I would consider using pethidine for a patient. And that's just because the intramuscular administration provides very high bioavailability of opiates. And although we don't like using pethidine because it's a dirty opiate, when it comes to the excruciating pain that is associated with a kidney stone or pancreatitis, the rapid relief that a patient gets allows you to then add on other agents as well. So I'm very old-fashioned. It's probably not supported by literature, but clinically at the bedside, it is very helpful to use an old drug like that. I don't like using it for anything else really, but this is the one time that I might consider it.
Thanks, Tammy. I will keep that in mind. Yeah, I haven't done that before, but I mean, if you're gonna get a rapid relief, that's probably a good place to start.
Cool. Thank you so much.